This next speaker is one that I had to beg to actually give a talk at his own conference. He's sort of the grand poobah at PCRI, and I want to get plenty of time with questions for him, but he's not only a good friend and a wonderful speaker, just incredibly knowledgeable, and this is the part of the introduction that I'm going to say really nice things, and I'll wait till after the talk to come after you. Let's bring up Dr. Mark Scholes, my good friend. Thanks.
I'm not going to go very far without slides. Ooh. Do we get it on the monitor here as well? There we go. Thanks everybody for coming. This is really great to see you all. I'm going to be talking about more advanced prostate cancer. In the morning we covered a lot of the early, do you do surgery, radiation type question. And this has always been a point of confusion for prostate cancer is why is one guy getting surgery, another guy getting hormones, chemo? And a lot of that confusion comes from there's many different types of prostate cancer, and that theme has come up already. And to try and simplify it further, we've since pink is the color for breast cancer, blue for prostate cancer, we thought in terms of different shades of blue for the different stages of prostate cancer. So you've heard about the low, intermediate, and high-risk prostate cancers. There's also another form when the PSA starts rising after surgery or radiation called PSA relapse, and then the more advanced stages if it gets into the bones or the lymph nodes. So my talk is going to be mainly focused on advanced prostate cancer. I'm going to have a few comments about the PSA relapse group. And just in passing, there's a book that my co-author is selling out there which goes into all the details of treatment for early stage surgery, radiation, seed implants, and whatnot. So that can be helpful to you. That is available to you. So for the PSA relapse, this is a type of disease that really doesn't exist for other types of cancers. And I think it's illustrated best by this slide. When you look at the average survival after a relapse of other common serious cancers like pancreas cancer, stomach cancer, it's fatal in rapid order. But with prostate cancer, a PSA relapse, people can live a normal life expectancy. And the majority of men with PSA relapse do live a normal life expectancy. So that creates all kinds of issues in terms of if they're going to live so long, there's a lot of potential side effects of treatment, and the benefits and the side effects have to be balanced out skillfully. So if you think of this is, I think, one of only 2 slides I have for the PSA relapse group, but this just summarizes the different treatments available. Dr. Tanya Dorf in the breakout session tomorrow is going to be talking about the PSA relapse group in more detail. But if the PSA is rising slowly, we think of just monitoring. The doubling is greater than a year, then the chances of the disease progressing within the lifetime is really quite low. Radiation, everyone's pretty familiar with that, either to where the prostate used to be, it's called the fossa, or to the lymph nodes in the pelvis. Hormone blockade, and it sort of falls into a nice category in terms of mild, medium, and strong hormone blockade. Mild being the Casodex pills alone, which are becoming more popular for relapsed men because it has less side effects. Lupron or Zoladex or Trelstar, these you're familiar with, sort of the old standard hormone therapy. And then a new medicine that was FDA approved just recently called Zytiga was actually approved for advanced disease, but there's no reason it can't be used in earlier stage disease. But it's more potent than Lupron. And we'll talk a little bit more about Zytiga. And then other medicines that are sometimes not considered, medicines that block the blood flow to the tumor, they're called angiogenesis inhibitors. And medicines that stimulate the immune system, you've heard of Provenge, but there's other milder products in the market that work that way by stimulating the immune system, Revlimid, Leukinus, and low-dose Cytoxan. So what about this new pill Zytiga? We've probably treated close to 100 patients with this since it's been FDA approved, and we're quite impressed with it. It's a pill, you take 4 pills once a day, and what's different about it, the Lupron and the Zoladex medicines block testicular testosterone. Casodex blocks adrenal testosterone. But what was learned in the roots of Zytiga's approval is that as cancer advances, it can start making its own testosterone and feeding off of that. And that fact, the testosterone can be zero in the bloodstream, but there can be substantial testosterone inside the cancer cells, and that's what's driving its growth. So the beauty of this new product is that it blocks the synthetic process. Testosterone is made originally from cholesterol, pregnenolone, DHEA, androstenedione. Dium. So between the chemical step between pregnenolone and DHEA, the Zytiga stops that and brings the testosterone levels inside the cancer cells down to negligible levels. So this was FDA approved because of a large randomized prospective trial. I'm going to show you a number of these type of trials where half the patients get the medicine, half the patients get a placebo, and then we monitor who lives longer. This sounds sort of a barbaric and unethical way to study things, mandated by the FDA, of course. And the only good thing that comes out of it is you get a very clear picture of the activity as to whether something is happening or not. The problem is that it doesn't measure how good the medicine is, and sometimes these trials are used improperly, and I'll talk a little bit more about that. So almost 1,200 patients, 2/3 got Zytiga, 1/3 got a placebo, and you're going to see these types of graphs, and it's very easy to interpret these graphs. You don't need to look at anything about whether or not the two lines on the graph separate. If they separate, then the upper line, which is the Zytiga, that group of men on Zytiga is living longer. And that's what the FDA wants to see before they'll put something on the market. That was confirmed with this study, and as a result, we now have this commercially available. So, but that's a pretty abstract thing, 600 people living this period of time. It's just an average of big groups. What happens with individuals varies greatly. So the very first person that we put on, we did some of the Zytiga trials in our office, was a 70-year-old gentleman that was diagnosed back in 2005. Originally, his PSA at the start was 6.4. He had surgery, but it was a worrisome stage in the seminal vesicles, and his Gleason score was high. So he had radiation right after the surgery and went on hormone therapy. But by 2007, his PSA was going up, bone scan had become positive, and there was an abnormal lymph node in his pelvis. He was treated with another older hormone treatment called ketoconazole, but couldn't tolerate it, and then went on a more potent type of Casodex, nilutamide, and his PSA did go down briefly, but then started to rise up to 5.6, at which time he was put on Zytiga. I've got his PSA graph here. And his PSA basically just floored, where it's remained to the present time. That's now, more than 2 years ago. So this is a real game changer for this gentleman. He has a normal quality of life, spends half of his time in Palm Springs and the other up to Seattle. And he's been able to go on with his life. And so these medicines, a medicine that was FDA approved for advanced disease, as I pointed out before, though, can be used at an earlier stage as well. There's really no reason not to, except possibly for insurance coverage reasons. This is another Zytiga patient. This is a brand new medicine, so we're learning new things about this as time goes on. And in this particular case, diagnosed 12 years ago, underwent surgery, radiation, had a relapse, treated with hormones, ketoconazole, chemotherapy, which we'll talk a little more about, Exempra, which is a breast cancer chemotherapy, which caused a lot of side effects, DES, which is a form of estrogen. Finally got on some Zytiga in December of last year. His PSA was a little above 10. And there wasn't a lot of things. He was refusing to go back on chemotherapy because of the side effects. And despite the fact his PSA kept rising and rising, he didn't want to change the treatment. And by early March, you can see his PSA had risen up to around 40. At which time, we didn't do anything at all. The PSA just decided to start going the other way after maybe, almost 3 months. So, and since that time, you can see his PSA sort of stabilized, and then more recently has taken a dip downwards again. This is something that the company has talked about, that you can get delayed responses to Zytiga, and that you need to stick with it. In fact, the trial that I showed you before, where they showed improved survival of men on Zytiga versus placebo, they didn't stop the Zytiga when the PSA went up. I think this is an important principle that just like Lupron is not stopped in men that are hormone resistant, because you don't want to give more testosterone back. that by staying on the Zytiga, not only might you see some delayed responses, but it may have an ongoing effect in terms of slowing the progression of the disease, even if it isn't stopping it. Now, it raises issues for mixing Zytiga with other new medicines that are coming on the market, like Provenge, you're going to hear about from Dr. Drake later, which works by stimulating the immune system. Zytiga is routinely given with a type of cortisone called prednisone, which inhibits the immune system, and therefore he raises the question, can you give Zytiga and Provenge together? But fortunately, there is a substitute, which many people are not aware of, called Inspira, which can be used in place of prednisone and allow the possibility of using combination treatment. The other question, Taxotere, which we're going to talk about more, is hasn't really been studied in combination with Zytiga, but we've ventured into this area and been able to successfully treat people with Taxotere on Zytiga by holding the Zytiga the day before, day of, and day after the treatment. And this is the evolution of all treatments in all diseases, not just prostate cancer. It's the idea of you get less toxic medicines that are effective, and then you're able to combine them with each other to get better results. So these are becoming considerations now that we have more and more things coming on the market. So like they did in the trial then, it seems logical once you start on Zytiga to stay on it, even if the PSA keeps rising. That's the way the trial was done. That's the way that you were able to show that men indeed did live longer with this medication. So the rest of my talk is going to be focused on Taxotere, chemotherapy type things. Dr. Kwan coming after me is going to talk about some of the results of the Mayo Clinic with immune treatments, and Dr. Drake, we're going to go into immune treatments in more detail as well. So one of the things, Taxotere has been on the market for a number of years now. It's based on the same kind of trial, randomized prospective trial. Half the men got Taxotere, half of them got a rather ineffective older medicine called mitoxantrone, which was kind of the standard before Taxotere came along. And we were able to show again that the Taxotere had better survival, and that and this is what got Taxotere FDA approved. They looked at the difference in the survival between the two arms, and unfortunately, it didn't seem like it was making that big an impact in 4 months. And this, I tell you, I must have heard the word 4 months thousands of times. And Taxotere is a type of chemotherapy, so it's not without side effects. You don't just give it willy-nilly to anyone. But this whole 4-month thing is an artifact of the FDA mandating these types of trials. The drug companies invest millions of dollars in these trials, and all they want to do is show in a horse race that the new product, I'll show you here, wins out against the old product. And voila, you're on the market. So it's not about how much you win the race by, it's whether or not you win the race. The FDA does not look at things like response in bone scans. On the right side, you see a bone scan, someone with a lot of disease that went on treatment and all the cancer went away. You think you could just wave this in front of someone at the FDA and say, my God, how can you say this doesn't work? Doesn't matter. They only want to look at survival studies. So this 4-month artifact, and how do we explain that? Well, if you look at the fact that only about half of the men that take Taxotere respond to it, and that survival improvement is occurring in the men that respond, not in the men that don't respond. Let me explain. In the left graph, you're looking at a separation of the curves that is somewhat wider. It's about a 10-month difference in survival instead of a 4-month difference in the men that had at least a 30% decline in PSA. The right-hand graph is in men where there was no reduction in PSA. The men on Taxotere, the men on mitoxantrone lived about the same amount. So response to treatment is critical, and unlike these trials where someone may stay on them indefinitely, in clinical practice, treatment will be changed if it's ineffective. Here's an example of what happens in the 115 of the 743 men that got Taxotere in the trial. 115 had their PSAs dropped down to normal, that is less than 4. So the average improvement in survival in the men that had this very good response to Taxotere was more like 20 months rather than 4 months. So this averaging out of big groups of people is great for the FDA, but it doesn't really tell you whether you're likely to respond, and if so, how good it's going to work for you. So in day-to-day practice, you have to monitor individuals closely with blood tests. There's a circulating tumor cells, PSA. There's a variety of blood tests that can give you an indication. Scans, which we heard about this morning. And after 2 to 3 months usually you can tell if the treatment is working, in which case you would probably continue it. If it's not working, there are other products and it's time to change to something else. In the morning, it came up briefly about sodium fluoride PET bone scans, and I'm a bit more enthused about them than the tenor of this morning's discussion. On the far left, the front and back of a standard technetium bone scan, we've been using these for 20 years. You can see some spots in the bones, which I imagine are easy to see. Now, the same patient on the far right had a sodium fluoride PET bone scan within a matter of a week. So we don't think the cancer changed in a week. What we're looking at is a scan that can actually see a lot of spots that the old scans can't see. So I think if you want to know the bottom line, are there spots present, you want to use these newer technologies. I think they're decidedly superior. So Taxotere is kind of old news, and that's been around for a while. The reason I present it as sort of a baseline, because we've learned since Taxotere was FDA approved that you can add other medicines to Taxotere and make it work better. So how do we decide if something is better or not? Because there aren't any big randomized prospective trials. And what we can do is look at how often PSA responses occur. To do that, we have to say, well, how often do PSA responses occur just with Taxotere by itself? And the answer was in the big trials that about 45%, almost half the men, would get a greater than 50% decline in PSA when they went on Taxotere by itself. So that's sort of our benchmark. 50% decline occurring in 45% of the men. So if we can get higher, more than 45% of the men to get that much PSA decline, then we've probably got something. So I've got some things to show you in that regard. A group of medicines derived from platinum. This cisplatin was a drug used to cure Lance Armstrong, who was so famous for beating cancer after it had spread to throughout his body. He had testicular cancer, a much more chemosensitive type of disease than prostate, but those same agents, specifically carboplatin or oxyplatin, are used commonly to treat lung cancer and prostate cancer now as well. So I just quote 3 small trials, 40 patients, you can see in the far left in the graph, and treated with Taxotere plus carboplatin and MSET. We don't use much MSET anymore, but you can see that all 3 of the trials showed better than 45% of the men getting a 50% decline. In one of the trials, 95% of the men had a 50% decline in their PSA. This is substantially superior without a lot of additional toxicity in my experience. So the one thing to consider then is that if we want to get higher response rates, more durable responses, is to combine Taxotere with carboplatin or oxyplatin, which is a type of chemotherapy FDA approved for colon cancer. Also, that's on the bottom line of the graph there. Another medicine FDA approved to treat breast cancer called Xeloda, a pill, in 2 out of 3 trials that I found, you can see that the response rates were higher than 45%. In one trial it was 73% of the men, another trial 68% of the men had greater than a 50% decline in PSA. And we've used Xeloda in men that are resistant to Taxotere, continuing the Taxotere but adding the Xeloda and seeing responses as well. A third category of medicines that could be combined with Taxotere are angiogenesis inhibitors. These are medicines that work by choking off the blood supply to the tumor. So you can see in this cartoon, illustrated on the left, a vibrant tumor with a lot of blood supply. And then after treatment, when you shrink the blood supply, you shrink the feeder tumor, blood vessels, the tumor itself will shrink. So there's 2 medicines. One was originally used as a sleeping pill in pregnant women in Europe in the 60s, known as thalidomide. And obviously that was a disaster, but some clever people thought that if it's cutting off blood supply, maybe it could be used as a cancer agent. And so this has been studied in combination with Taxotere in a small randomized trial. Taxotere and thalidomide in 2/3 of the men, and then Taxotere alone in 1/3. And there was, again, looking at these curves, remember if they separate, that means something is substantial is happening. In this case, the median survival for the combination was almost 27 months, and in the Taxotere alone arm, only 14 months. Another angiogenesis inhibitor is Avastin. This is being used to treat wet macular degeneration. It's also used to treat colon cancer. And a very large trial has been done with Avastin with Taxotere or Taxotere alone in 1,000 men. They didn't show a significant survival advantage, but they did show an improvement in PSA responses and scan responses. So a guy named Dr. Fig did some studies with 60 men who had what I would consider very, very worrisome prostate cancer. These men had an average PSA doubling time of 1.6 months. Average Gleason of 8, PSA 99, and half the men were having pain somewhere. This is really serious prostate cancer, about as serious as you can imagine. He gave them the combination of Taxotere plus thalidomide plus Avastin. And in that study, it illustrated all 60 men's PSA responses are illustrated in this, this type of a graph. Basically, any of the lines that go down, that means the PSA went down. Any of the lines that go up, and there's only 2 or 3 of them on the very far left that didn't respond to this treatment. You can see the little dotted line that goes across the bottom there. That's when they had more than a 50% decline in PSA. So about 9 out of 10 men had more than a 50% decline in PSA on this treatment. So we've mentioned 3 things: carboplatin, Xylota, and then the combination of Avastin plus thalidomide really stimulate the activity of Taxotere further beyond what Taxotere alone can do. There's a 4th medicine that's still in trials that is really intriguing. I like to present medicines that people have access to right now. You can go out and get the things that I've been talking about. This is only available on a trial, although it's probably not too hard to get on a trial. There's a number of centers around. But I also present this because it creates in me a lot of hope as the type of new solutions. Most of the medicines we've seen work by blocking proteins or inactivating proteins that are creating problems. This medicine works by basically blocking the protein from ever even coming into existence. And I'm going to illustrate that for you. The new medicine is called Curstersin. And what it does is it gets rid of a protein inside the cancer cells, which basically inactivates chemotherapy. So if you can get rid of this protein that activates chemotherapy, in theory, the chemotherapy will work better. So the protein is called clusterin, and the medicine is called Curstersin. So this is the way these cells make the protein. You see the RNA on the bottom. It's being synthesized, manufactured off of the RNA, and the little chain coming up is the protein itself. So this is a little too complicated for me. All right. So far left, DNA, arrow goes to a blue strip, which is RNA, which you saw in the previous slide. That RNA then gets translated into clusterin at the far end of the manufacturing line. The Curstersin, the new medicine, is kind of like an anti-RNA that sticks on the blue RNA so that the RNA can't make the protein at all. So the drug is actually sort of an RNA type thing that you get by an intravenous infusion, and it goes in and gets rid of clusterin mRNA, and therefore you eliminate the Curstersin inside the cancer cell. Now, does that work? Well, there is actually a study, a preliminary study. It wasn't big enough to satisfy the FDA, and just because it had positive results, that doesn't mean anything. But the 82 patients, half got Taxotere plus Curstersin, the other half got Taxotere alone, and you can see again the lines separate. Substantial difference in survival for the men that got the combination. So this, again, let's try and bring this home. We were running this trial. This is the first patient that we put on this trial. Diagnosed in 2007 originally, PSA of 12, Gleason 9, had surgery, went on to have a PSA relapse, hormone therapy, and then developed hormone resistance in last fall. Bone scan became positive, lymph nodes were growing. So he went on this trial. He had never had Taxotere before. Went on Taxotere and Curstersin in January. And here's his PSA response so far. He's still on it. PSA was around 100, as I mentioned. And he has had another PSA since this 6.5. He's now down into 4 something. So it's just steadily continuing the cancer to go away. So in summary, the things that you want to think about if someone has a more serious type of prostate cancer that needs chemotherapy is trying to enhance the results further with some of these additional things, such as carboplatin, Xeloda, Avastin and thalidomide, or possibly this new investigational agent, Curstersin, and there are other investigational agents as well to consider. The last medicine I want to talk to you about is sort of like a new improved Taxotere. The Taxotere works by blocking out the spindles. At the bottom you see a mitotic cell. Mitotic means dividing cell. Those long yellowish brown sticks are the spindles that are pulling the cell so it will become two cells ultimately. Taxotere stabilizes that so that the cells can't divide. Pretty clever. And this is how basically Taxotere works. Jevtana works the same way. But the difference between these medicines, well, first let me explain to you how the cancer cells figure out after a period of time how to get rid of the Taxotere. So there's a pump in the membrane of the cancer cells that is pumping the Taxotere out of the cell so that the Taxotere can't continue to block the tubules, as illustrated here, and then the cancer can start growing again. So the beauty of the Santa Fe Adventist biochemists is they figure, well, why don't we get a type of Taxotere that clogs the pump? And all they did was they added a couple methyl groups. I know this complex thing doesn't mean anything, but you can see circled in yellow there. They changed the molecule slightly, so it didn't alter the activity of the Taxotere, but it did make the medicine stick inside the cancer cell. So again, the question is, does it work? Back to the FDA, 755 men, half of them get the real stuff, half of them get the stuff that doesn't work. That's called the mitoxantrone. And then these are all men who had previously been on Taxotere and it was no longer working. So this is a tough group. They've been through Taxotere and their PSAs are rising, their bone scans are getting worse. And they were able to show separation of the curves in that very, very difficult patient population. So the men on the Jevtana outlived the inactive, old-style mitoxantrone treatment. So I'm going to give you an example of this. This is a patient, one of the early patients we put on Jevtana. Been fighting prostate cancer since 1996. He started with a PSA of 29, had a seed implant, relapsed in 2004. Subsequently was treated with hormones, bronchiticonazole, Taxotere, estrogen, got some spot radiation for a painful area, went on nilutamide, which is like a souped up form of Casodex, as I mentioned before. Went on Taxotere with Avastin, got some more spot radiation, went back on Taxotere with Avastin, this is back in July of 2009, got some more radiation, and by the time you're looking in late last year, this man was in a wheelchair, it didn't look like he was going to be with us much longer. PSA was up to 650. Went on Jevtana, and this is his PSA since that time. He's gotten out of the wheelchair, he's walking around, he's got his life back. I was talking with him a week or two ago, and they're thinking of possibly taking a trip. So this is a miracle. I mean, this man had been through every known treatment, and it looked like it was all over, and now with this medicine, his life has been changed. So this is so Jevtana is like Taxotere. It sounds like it's definitely a better drug than Taxotere in that it's more likely to cause durable responses. It has a little higher incidence of diarrhea than Taxotere does. No one's yet tested whether we can mix this new medicine, Jevtana, with some of the things we've already mentioned, but it's logical that we can. So to summarize then, just for people out there, so I've presented all these different things. How do you pick between the treatments that you use now, that you wait? How do you sequence these things? And this is becoming more of an art form now that we're getting more and more choices. But the underlying principle is that you're always looking at the potential side effects of the treatment versus the potential benefit. And you individualize these decisions and you have a dialogue so that people can participate in that decision. It's clear that combination treatments are better than single agent treatments. There are more side effects with combination treatments, so it has to be justified that you want to be more aggressive. I've pointed out that there's some very exciting clinical trials, and this is going to go, Dr. Drake is going to go over some other very exciting things that are coming online as well. I think one thing to be emphasized is, and I don't know why even people think about waiting around till their PSA goes up and then think, well, maybe I'll treat it now. Cancer responds better at an earlier stage. So now that we have non-toxic medicines such as this immune medicine Provenge, which is extremely well tolerated, and we know that immune treatments work earlier, we want to get going earlier. When a relapse occurs, we want to start using these medicines so that people can get the maximum benefit. When the disease gets very advanced, it tends to suppress the immune system, and it's going to decrease the effectiveness of those types of treatments. So, final slide, I think, here. Zytiga, although it's FDA approved for after Taxotere, because that's the way the trial was originally designed, it's logical, really, to consider it before Taxotere. We've pointed out Taxotere is sort of the standard of treatment for advanced disease, but combinations are clearly better than the single agent. And Jevtana looks like it may become the new standard in short order. So, thank you very much. Trying to sneak off there.
Okay. I am introducing you to the Moyed hot seat.
No, wait a minute. If we're going to do that,
So
I'm going to need
I need you to be on this hot seat. I don't know why you're the first, but it seemed logical that you would be the first in the hot
up here for the other speakers.
I know, but this is for you. So anyway, I feel like we're going to do a duet or something like that.
We already did a dance?
We did a dance. That's true. You were my dance partner. I want you to see if you can guess this song and tell me the relevance of this song in your life. Okay?
I'm terrible with songs, but he'll make it easy, right? Trojans!
What is that? Do you say Trojans? The condom or the school? Sorry, that's always an easy one back where I live. So, what's the significance of USC in your life?
Well, do you want the short answer?
Short answer. I got lots of questions.
I attended SC for 2 years as an undergraduate, and then I went there to do all my postgraduate training.
There you go. He's a USC man. He's a local guy. He stayed local, which I like. So, okay. Now, since you got that right, I have another question for you. We're going to bring up a picture. Okay, so here's a picture. See if you can see that photo. That's me.
That part I got. I don't know who the other one is.
You don't know who the other person is?
Who's that? Oh.
No? No guesses?
Oh, he was, I just met him today.
No, sorry, you got that wrong. That's Brady Hoke. He's the new head coach of the University of Michigan football team.
Oh.
So your penalty is you have to wear this during my Q&A.
He looked a lot like Dr.
You have to wear that during my Q&A.
Where do you put this?
You put that on your wristband. It's a wristband. You put that, and then we'll just put this here, and we'll start the Q&A. All right? For getting that wrong.
Whose wrist is this supposed to fit?
That's supposed to go on your wrist for getting that wrong. You got the USC. I gave you the easy one, and then you got the slightly harder one wrong. All right. That's your punishment. So, before I come up with, don't put up that third slide yet, I got to ask you something, and we're going to leave your topic for a second. You wrote a book called Invasion of the Prostate Snatchers with Ralph Blum. And what does Invasion of the Prostate Snatchers mean? Because the book sold well, so what were you trying to get at when you guys named that book Invasion of the Prostate Snatchers?
It sort of alludes loosely to surgery.
Well, what do you mean by that? I need you to be more direct. You sound like a politician.
I have friends who are surgeons.
Some of my best friends are surgeons. So,
let me jump in
behind it?
Let me jump in with both feet. I mean, it's prostate cancer is a surgically run. 99% of the doctors out there are surgeons, and that's unusual. All the other cancers are managed by medical oncologists like myself. So, to try and balance it and level the playing field, we thought we'd write a book that hopefully people could read before they have surgery. So here are all your options.
Okay.
Yeah.
So you do active surveillance even though you're an oncologist. Is that correct?
Oh, yeah. We've got hundreds of patients on active surveillance.
How many people would you say you have on active surveillance right now?
We've never counted them, but we estimate maybe over 400.
400.
Yeah.
So, and I asked the question to Klotz. I said, if you were on active surveillance, would you also take one of those pills like finasteride and Avodart? And is that something that you espouse, or do you watch them without any intervention?
We espouse it. Avodart and Proscar, however, do occasionally affect sexual function. And since we've deemed these active surveillance patients to be so benign they don't really need any treatment. If they have any side effects on the Avodart or ProScar, we stop it. But we do believe it's beneficial.
Okay. But that was an interesting book, Invasion of the Prostate Snatchers. If you haven't seen it, it's a very good book. At the same time, they upset a lot of surgeons, I think. And so I would be, if I were you, I would just be careful when you start your car in the morning. That's all I'm saying. I'm not saying anything else besides that. I mean, you basically said in the book that you've identified the biggest risk factor. Tell me if I'm wrong now. You basically said in the book that you've identified the biggest risk factor for prostate cancer today, and that is basically a biopsy.
Well, we didn't say it. I wish we'd said it that succinctly.
So it is interesting, though, and so he does actually have a lot of patients on active surveillance and also uses some therapy with them and some not. But you also depend a lot on pathology, is this correct?
Yes, it's really wonderful. In previous years, I sounded like the voice in the wilderness, but you've gotten a wonderful, concise, but uniform message from all the doctors this morning that biopsies, imaging with high-quality MRI, PSAs, you watch all of these things, and we believe that we haven't eliminated the risk, but we've sure lowered the risk of missing something.
Okay. Now, before I'm gonna ask you another question. Can we bring up the other slide, the next slide I want to show them? I want to show them one Moyed slide. So, here's my question. Maybe we got more question music. Don't we have another question music that's sort of profound? There you go. Who wants to be a millionaire? Why should I really be excited? Because I want to shift gears now and go to what you've been doing a lot. You've been working a lot with bone drugs. And I want to shift gears here. And I don't know if you know this, if you're aware or not, but on Friday, yesterday, the FDA convened a panel that said essentially that they're really worried about these bone drugs that you oncologists are using all the time. One thing you can get is osteonecrosis of the jaw. That doesn't sound too good, where part of your jawbone erodes from an infection, basically. You can get serious flu-like symptoms. There's a question on whether or not you get atrial fibrillation, some atypical fractures, and if you take the pill, possibly some esophageal problems. So this was this big meeting yesterday, and we'll see what the outcome is. But you're a big fan of bone drugs. How can you be a big fan of bone drugs when you look at that list? That list is just scary. So tell me why you're a fan and what you're a fan of.
Well, the main issue with those medicines is that if an elderly guy has a hip fracture, 50% of the time he dies from it. So these medicines are proven to reduce the incidence of hip fractures significantly. All these things can happen. Osteonecrosis of the jaw is probably the most horrifying one, but we found that if a person encounters that and you stop the medicine, that it does heal. And that wasn't understood early on because they didn't even know what was causing it. So like everything we do in oncology, after I've told you about chemotherapy, you're going to make me worry about this? I mean, come on.
Yeah,
no,
absolutely.
Not everyone should get these medicines, but if a person has serious osteoporosis and is at risk for a hip fracture, the risks are less, but there is always risk.
But a lot of the guys who come to you, they're already on Lupron, they're already on a hormone therapy. Their testosterone is basically close to zero.
Yeah.
They're in male menopause, right?
And at higher risk for osteoporosis.
And higher risk. So how do you work that out with imaging tests, how you determine whether or not they need a bone drug and are actually at higher risk for osteoporosis? What do you do?
Well, you're giving me a chance to talk about my pet peeve. There's actually two types of scans, DEXA scans, which I would contend are for women, and QCT scans of the spine. Men get osteoporosis in the spine about 10 years younger than they get it in the hip, and the DEXA scan can't see the spine. So we recommend QCT scans to find out if osteoporosis is present, and when you look for it, it's a lot more common than people realize.
So two scans, DEXA, D-E-X-A, QCT, they're just like it sounds, quantitative computed tomography, and you prefer the QCT. Okay. Now it comes to the drug for the bones. Do you use the pills? Do you use the IV?
Or do you use the newer injection that I'm reading all about, and I get these slips underneath my door that says, come to this conference and hear about our new bone drug? So which bone drug do you prefer for your patients?
Well, we can't get Xgeva for osteoporosis in men. So we're only using it for men with bone metastasis. That's the third one that Dr. Moy had mentioned. The pills are more convenient, and now they have once a month preparations, so we'll start with those usually, and if people can't take them for some reason or another, then there are intravenous forms you can use as an alternative.
Do you put all of your patients who are on hormone deprivation treatment like Lupron, do you put them all on a bone drug?
Yes.
Why would you do that? That sounds like aggressive treatment.
It is. The studies show that you can lose about 10% of your bone mass in the first 6 months of Lupron treatment. And in my experience, it's a lot harder to get it back than it is to lose it so quickly. So we put all our patients on Fosamax or Boniva or Actonil while they're on the hormone therapy.
And now, who are you putting on the IV drug? The IV drug seems kind of simple. How often do you put them on Zometa, or do you put them on Zometa anymore? Because now there's competition, right? You got the IV Zometa, and then you got Xgeva.
Now you're talking about bone metastasis.
You're talking about bone metastasis.
Yeah.
So now
we've got about, well, of course, everyone that had bone metastasis was on Zometa originally. Now that Xgeva has come on the market, there is a head-to-head study that suggests that Xgeva is a little bit more effective in terms of preventing fractures and whatnot. So slowly patients are migrating over to the Xgeva.
do you think these bone drugs not only preserve bone but also slow the progression of the disease?
In the original Zometa trials, they showed a trend towards better survival with Zometa compared to placebo. It didn't become statistically significant. There are logical reasons to believe that these medicines are making... What's this thing on my wrist?
Okay, go ahead.
There are logical reasons to think that these medicines make the bone environment less hospitable to cancer. And so there are trends to suggest that, but it's not a dramatic difference.
So you're not worried about all this stuff in the slides? Or do you think that that's just more minor risk?
Well, everything us oncologists do have scary implications. I mean, this is relative to a hip fracture, though. These are worthwhile risks to take.
Okay.
Yeah.
I got two general questions for you. Just think about, off the cuff. What do you think the biggest mistake is that doctors make when it comes to hormone refractory prostate cancer or the type of patients that you treat? What do you see? What's one of the biggest mistakes you see out there by doctors, other than yourself, of course?
Well, I think you already pegged it, Mark. The most common thing is the failure to check for osteoporosis. And we see second opinions from people that have been on Lupron for 5 years. They've never had a bone density test. All the time. If we see a bone density test, then we're actually surprised. So this is being missed. I'm so glad that you already highlighted that. That's, I think, far and away the most egregious error. The other error is that it was pointed out by Dr. Demanis that there's a lot of controversy about how much hormone blockade to give, how long, and sometimes, people there's no right answer, but there's people that give too much and too little. That's probably the second most common thing.
So that's the biggest mistake you think doctors make? They don't order the bone tests for their patients.
Yep.
So then what's the biggest mistake patients make and when they see an oncologist? What do you think is one of the top errors that a patient might make when going to see an oncologist? Because we have a lot of bad oncologists out there, right? Not you, of course. But
the only, I say, the early stages of prostate cancer, oncologists don't generally see those people. We're talking about advanced stages. I think the oncologists do a pretty good job. Maybe they're not aware of some of the things we talked about, that combinations are more effective. But it's a real problem when people go see an oncologist with newly diagnosed prostate cancer, and the oncologist says, "Why are you here? Why don't you go see a urologist? I don't understand this early stage stuff." So us oncologists are not getting trained in the early stage prostate cancer.
Let's talk about a couple of treatments before I get you off the hot seat, get your opinion on it. We've already heard some of it, all right? Provenge. Do you give Provenge in your practice?
Yes.
The immune therapy?
Mm-hmm.
And
Can you give us a quick overview? And not how necessarily it's given. Are you happy with it? Have there been certain surprises? It's a very controversial drug in some sense, right? Because what I hear is it's expensive and you only live 4 months.
He didn't listen to my talk.
I did listen to your talk. I just got a lot of friends who are urologists.
We've given quite a bit of Provenge. The beauty of it is compared to all the things we talked about today, it has almost negligible side effects. I mean, a little low-grade fever sometimes. The confusing thing about it is it doesn't make PSAs plummet to zero like the things we've shown today. And people wonder how can this translate into longer survival. And the way I understand it is this is a medicine that works by turning your immune system on, and it stays on indefinitely for the rest of your life. And what we believe is happening is that the rate of cancer progression is being slowed significantly. And so you're not seeing these rapid reversals, but you're seeing a change in growth rate. And I think as we go forward and get more of these immune treatments, we're going to see things added to the Provenge. I think this is the first break in the dam, and I think that we're going to see an explosion of active immune treatments in the future.
So after they finish their Provenge treatment, do you immediately look to put them on something else, or do you wait a while?
If it's a non-immune treatment or a chemotherapy treatment, it's advised to wait a few months to let it put down roots and get, because chemotherapy and prednisone, as I mentioned earlier, cortisone, can suppress the immune system. So you don't want to fight the Provenge in the first few months after the treatment.
Okay. How about Taxotere? Tell us a little bit. So how often are you giving Taxotere? Once every how many weeks? Take us through that. And then take us through the side effects of Taxotere that worry you the most, that you talk about with patients. I mean, the list of side effects is scary. There's about 12 up there. Mm-hmm. But which are the side effects I really need to worry about, and how often do I really need to get this drug?
Well, far and away, the side effect that we worry about is tiredness. This is the same problem we see with Lupron. This is the same problem we see with aging. And then Taxotere, radiation can cause tiredness, and then Taxotere is more of the same. It can be like a piling on. So the only thing we found that consistently helps is fitness and exercise. The same thing we learned with Lupron. If people can get exercise and stay strong, they're able to tolerate these things better. But that's the bugaboo of our lives, is tiredness from all these different agents.
And I hear that there are some cases out there that when you get Taxotere, the PSA can actually go up a little bit before it goes down. Mm-hmm. Can you tell me about that for a second? Because that would scare some doctors to take them off of Taxotere when actually it takes a while to get a response. Tell me your experience with that.
Sure. They call it a PSA flare, and it can last for up to a couple months afterwards. And it's thought to be because the chemotherapy is killing off cancer cells and the PSA is being released into the bloodstream. So you don't want to, as in the slide that I presented, wait 60 to 90 days before you jump to change to a different treatment.
Okay, and do you see anything like that with Zytiga? So Zytiga is just the trade name, it's the commercial name for abiraterone. So now they've got a fancy name, Zytiga. And so with Zytiga, I saw some paper that said essentially it looked like the bone scans might be getting worse, but in reality the patients were doing pretty well. So tell me your experience on Zytiga. And how many pills a day are you putting these patients on?
So 4 pills once a day.
Am I taking the 4 pills with or without food?
You're taking them on an empty stomach.
Okay.
So the interesting thing on bone scans is that the hot spots can get brighter when your bones start healing. So inexperienced people that read these things will talk about the scan being worse when it may just be a healing reaction. The way you can tell a scan is worse if new spots appear. But don't fall for the thing that the scans look brighter, I got to change my treatment, because it could just be the healing bone.
Can I get Zytiga right when I stop responding to Lupron? Or hormone therapy?
In theory, since the FDA only approved it for after Taxotere, in theory you can't. But in practical terms, we've been able to get patients, they do want to see some form of metastatic disease and a rising PSA with a low testosterone. Some of the drug insurance companies are paying for it, though, and some aren't. Yeah.
I heard there's a rumor out that when you take Zytiga with food, it increases the drug concentration substantially. So the thought process is all these drugs are expensive. right? I mean, you guys give a ton of expensive drugs, which means that's probably why you're driving really nice cars. And I drive a Geo Prism, so that tells you about my life. So the theory is that apparently when you take it with food, especially a fatty meal, that the drug concentration increases significantly. So I opened my big mouth and said, hey, maybe you could just take a couple pills instead of 4, take 2 and save, get a 50% discount. And then one of the members of the company wrote in and basically said, we don't advise that, which to me means I'm right. So tell me about that. And I mean, we love the drug, there's no question, but tell me about that. Are you looking at ways to possibly manipulate this dose, or am I just coming up with this theory?
In situations where you can afford 1 and not 4, I'm aware of this phenomena, but I'm not sure exactly how dramatic it is. And so right now it's such a new medicine, we're so thrilled with the kind of results we're seeing, we don't want to mess with success. But those sorts of studies need to be done. Can you get by with less medicine and better absorption?
Okay. Now we're out of time, but I want you mentioned a buzzword that's not going to probably come up again, so please give a quick explanation. You mentioned a blood test called CTC. Can you please explain that blood test and the relevance to everyone here, what a CTC blood test means?
It stands for circulating tumor cells. They can actually measure cancer cells in the blood now. It's really only useful in people that have a positive bone scan. It doesn't show up in earlier stage disease, so don't think of it there. And the beauty of it is it's a cross-check. We mentioned how if the PSA goes up, what does it mean? And so having those other tests, PSA, besides PSA, PAP, LDH, and CTC, gives you a way to really know what direction you're going, because if things aren't working, you want to stop what you're doing and change to something that is working.
Okay. So my Oscar moment is that, in all seriousness, Mark has been a good friend. I probably talk to him once a week, and we probably argue once a week about certain things, but we get along well, and I appreciate what you've done to move this organization forward, and I just want to, I thank you for your time, and I thank you for, pushing medicine toward the edge and making people think. So thanks a lot.